The Thermoregulatory Storm, a comprehensive report on the pathophysiology and management of menopausal vasomotor symptoms. The menopausal transition represents a universal and natural biological milestone in a woman's life, defined by the permanent cessation of ovarian function and the subsequent profound decline in circulating estrogen levels. While this transition marks the end of reproductive capacity, it is often accompanied by a constellation of symptoms, the most prominent and disruptive of which are vasomotor symptoms, VMS, commonly known as hot flashes and night sweats. VMS are characterized by sudden transient sensations of intense heat, often accompanied by profuse sweating and a reddening of the skin, affecting up to 80% of women navigating this phase. The impact of these physiological events extends far beyond mere discomfort. They can severely compromise quality of life by disrupting sleep, impairing concentration, and negatively affecting mood and daily functioning. This report provides a comprehensive, evidence-based synthesis of the intricate neurobiological mechanisms that precipitate VMS and critically evaluates the full spectrum of available management strategies, from hormonal and non-hormonal pharmacotherapies to lifestyle modifications and complementary approaches. Show your support for women's health with a quick like, share, and subscribe. At the core of the body's ability to maintain a stable internal temperature is the hypothalamus, a small but critical region of the brain that acts as the master thermoregulatory control center. Specifically, the preoptic area, POA, of the hypothalamus is responsible for monitoring core body temperature and orchestrating the physiological responses necessary to keep it within a narrow, stable range known as the thermoneutral zone. Within this zone, the body is in a state of thermal comfort and does not need to activate significant heat loss mechanisms, such as sweating and cutaneous vasodilation, or heat production mechanisms like shivering. Female reproductive hormones, particularly estrogen, play a fundamental role in modulating this delicate system. Estrogen exerts a stabilizing influence on the hypothalamus, effectively widening the thermoneutral zone and promoting heat dissipation responses. This hormonal regulation ensures that the body can tolerate minor fluctuations in core temperature without triggering an extreme corrective response. The dramatic decline of estrogen during the menopausal transition critically destabilizes this system. The hypothalamic thermostat becomes hypersensitive, and the thermoneutral zone narrows significantly. Consequently, even a minuscule, previously imperceptible increase in core body temperature can cross the new, lower threshold for sweating and vasodilation, leading the brain to erroneously perceive the body as overheating. This results in the powerful, inappropriate, and sudden activation of heat loss effectors that is experienced as a hot flash. The KNDY neuron hypothesis, a breakthrough in understanding VMS. For decades, the precise link between estrogen withdrawal and the triggering of a hot flash remained a black box. A major breakthrough came with the identification of a specific population of neurons within the arcuate nucleus of the hypothalamus, now known as KNDY-kispeptin/neurokinin B dynorphin neurons. These neurons are a key component of the neural circuitry controlling reproduction and are powerfully and negatively regulated by estrogen. In the premenopausal state, circulating estrogen acts as a brake, suppressing the activity of KNDY neurons. During menopause, the loss of this estrogenic inhibition unleashes these neurons. Freed from their hormonal restraint, KNDY neurons undergo significant neuroplastic changes. They become larger, somatic hypertrophy, and dramatically upregulate their production of the neuropeptides kispeptin and neurokinin B, NKB. This state of hyperactivity is now understood to be the central upstream event that initiates the VMS cascade. Evidence from animal models provides compelling support for this hypothesis. The targeted, artificial activation of KNDY neurons in mice reliably provokes a physiological response, including cutaneous vasodilation, flushing, and a subsequent drop in core body temperature that precisely mimics a hot flash. Conversely, the experimental ablation destruction of KNDY neurons in rats leads to a consistent reduction in cutaneous vasodilation, demonstrating that these neurons are not just correlated with, but are necessary for facilitating this cardinal heat dissipation mechanism. The elucidation of the KNDY neurons' role led directly to the next crucial question: how does the hyperactivity of these neurons translate into a full-body thermoregulatory event? The answer lies in one of the key neuropeptides they produce, neurokinin B, NKB. NKB has emerged as the primary downstream signaling molecule responsible for triggering the hot flash itself. The causal pathway is now understood with remarkable clarity. The disinhibited and hyperactive KNDY neurons in the arcuate nucleus release bursts of NKB. This NKB then travels to the thermoregulatory center in the preoptic area and binds to its specific receptor, the neurokinin 3 receptor, NK3R, which is expressed on temperature-sensitive neurons. This binding event is the final molecular switch. It acts as an excitatory go signal, incorrectly informing the thermoregulatory center that the body is dangerously overheating. This false alarm triggers the immediate and powerful deployment of heat loss machinery, including systemic cutaneous vasodilation and sweating. This mechanism is not merely theoretical or confined to animal models, it has been validated in humans. In a landmark study, the intravenous infusion of NKB into healthy women reliably and rapidly induced the classic symptoms of a menopausal hot flash, including elevations in heart rate and skin temperature. Furthermore, large-scale genetic analyses have identified specific single nucleotide polymorphisms, SNPs, in the gene encoding the NK3R that are associated with a significantly increased predisposition to experiencing VMS. Together, this evidence solidifies the NKB/NK3R signaling pathway as the central and final common pathway for the generation of a hot flash in humans. This discovery has fundamentally shifted the therapeutic landscape, moving beyond simple hormone replacement to the possibility of targeted molecular intervention. Beyond KNDY, the influence of serotonin and norepinephrine. While the KNDY/NKB pathway represents the primary trigger for VMS, the neurochemical environment of the menopausal brain is further complicated by changes in other critical neurotransmitter systems. Estrogen is not only a reproductive hormone, but also a master regulator of brain chemistry, and its decline has wide-ranging effects. It is known to stimulate the production of serotonin, a neurotransmitter crucial for mood, sleep, and thermoregulation. Consequently, the fall in estrogen during menopause is associated with a corresponding 50% decrease in brain serotonin levels. This reduction in serotonergic tone is believed to have a secondary, destabilizing effect on the hypothalamic thermostat, primarily through its relationship with norepinephrine. A decrease in serotonin leads to a relative increase in the activity of norepinephrine, another key neurotransmitter involved in arousal and stress responses, which further disrupts thermoregulatory control. The evidence for the involvement of these systems is largely indirect but clinically compelling. The proven efficacy of certain antidepressant medications, namely selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs, in alleviating hot flashes, provides strong clinical validation that these neurotransmitter pathways are indeed important contributors to the pathophysiology of VMS. Menopausal hormone therapy, MHT, the gold standard reevaluated. For decades, menopausal hormone therapy, MHT, also known as hormone replacement therapy, HRT, has been recognized as the most effective treatment for alleviating moderate to severe VMS. The principle of MHT is straightforward. It addresses the root cause of VMS by replacing the estrogen that the ovaries no longer produce, thereby restabilizing the hypothalamic thermoregulatory center. There are two primary MHT regimens, determined by whether a woman has a uterus: estrogen-only therapy, ET. This regimen is prescribed for women who have undergone a hysterectomy. Administering estrogen without opposition in these women provides symptom relief without posing a risk to the non-existent endometrium. Estrogen-progestin therapy, EPT. This combination therapy is essential for women with an intact uterus. Unopposed estrogen stimulates the growth of the uterine lining, endometrium, which can lead to endometrial hyperplasia and an increased risk of endometrial cancer. The addition of a progestin, a synthetic form of progesterone, counteracts this effect and protects the uterus. MHT is available in a wide variety of formulations and delivery systems, allowing for individualized treatment. These include oral tablets, transdermal patches, and topical gels, emulsions or sprays. There are also local, low-dose vaginal preparations, creams, rings, tablets, designed specifically to treat the genitourinary syndrome of menopause, GSM, which deliver minimal systemic doses of estrogen. The route of administration is a key consideration. Evidence suggests that transdermal delivery via patches or gels may be associated with a lower risk of venous thromboembolism, VTE, and stroke compared to oral estrogen, as it avoids the first-pass metabolism in the liver. The Women's Health Initiative, WHI Legacy, a nuanced view of risks and benefits. The perception and prescription of MHT were irrevocably altered by the Women's Health Initiative WHI trials, a series of large-scale, randomized, placebo-controlled studies initiated in the 1990s to assess the risks and benefits of MHT for chronic disease prevention. In the early 2000s, the trials were stopped ahead of schedule due to the emergence of unexpected risks. The EPT arm was halted after an average of 5.6 years due to an increased risk of invasive breast cancer, and the ET arm was stopped after 7.2 years due to an increased risk of stroke. These initial findings generated widespread alarm alarm among both clinicians and the public, leading to a dramatic and precipitous decline in MHT use. However, the story of the WHI is a powerful lesson in the importance of scientific re-evaluation and data stratification. Subsequent, more detailed analyses of the WHI data revealed a critical flaw in the initial interpretation. The study's overall cohort was, on average, significantly older, mean age of 63, than the typical woman who starts MHT for the management of menopausal symptoms. When the data were reanalyzed and stratified by age and time since menopause, a much different and more nuanced picture emerged. This gave rise to the timing hypothesis, which posits that the benefit-risk profile of MHT is critically dependent on when it is initiated. For women who begin MHT close to the onset of menopause, defined as being younger than 60 years of age or within 10 years of their final menstrual period, the absolute risks of adverse events are low. In this younger population, MHT is not only highly effective for VMS, but may also confer a cardiovascular benefit and reduce all-cause mortality. Conversely, for women who initiate MHT many years after menopause, the risks, particularly for coronary heart disease, stroke, and VTE, are demonstrably higher. Modern guidelines for candidacy, an evidence-based framework, drawing heavily on the nuanced lessons from the WHI and other studies, major medical organizations, including the North American Menopause Society, NAMS, and the American College of Obstetricians and Gynecologists, ACOG, have established clear, evidence-based guidelines for MHT use. The cornerstone of these modern guidelines is the consensus that for most healthy, symptomatic women who are under the age of 60 or within 10 years of menopause onset, the benefits of MHT in relieving VMS and preventing osteoporosis significantly outweigh the potential risks. MHT is not appropriate for everyone, and there are clear contraindications. Women with a personal history of breast cancer or estrogen-dependent malignancies, like endometrial cancer, undiagnosed abnormal vaginal bleeding, a history of VTE, deep vein thrombosis or pulmonary embolism, or stroke, active liver disease, or known coronary artery disease, should generally not use systemic MHT. The bioidentical hormone debate, separating marketing from medicine. In recent years, the term bioidentical hormones has become a source of significant public interest and confusion. It is crucial to distinguish between the scientific definition of the term and its use in marketing. Scientifically, a bioidentical hormone is one that is chemically and structurally identical to the hormones produced by the human body, such as 17-beta-estradiol and micronized progesterone. The central issue in the debate is not the chemical structure of the hormone itself, but rather its source and regulation. A critical distinction must be made between two categories of products. 1. FDA-approved bioidentical hormones. Many FDA-approved and regulated MHT products contain bioidentical hormones. These are manufactured by pharmaceutical companies, are available in standardized tested doses, and have undergone rigorous clinical trials to establish their safety and efficacy. These products are recommended by major medical societies. 2. Custom compounded bioidentical hormones, CBHT. These are preparations that are custom mixed by compounding pharmacies based on a provider's prescription. They are often aggressively marketed with claims of being natural, safer, and superior to conventional MHT, targeting neurotransmitter pathways, SSRIs and SNRIs. The most established class of non-hormonal treatments for VMS are certain antidepressant medications, specifically selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs. Their efficacy provides clinical validation for the role of serotonin and norepinephrine in thermoregulation, as discussed in Part 1. These drugs are thought to work by increasing the availability of these neurotransmitters in the hypothalamus, which helps to stabilize the now erratic thermoregulatory center. A low dose of the SSRI paroxetine salt, 7.5 mg, brand name Brisdel, is the only non-hormonal therapy currently approved by the FDA specifically for the treatment of VMS. However, several other agents are used effectively off-label, including the SSRIs escitalopram and citalopram, and the SNRI venlafaxine. The efficacy of these agents is modest compared to MHT, but significantly superior to placebo. Clinical trials have demonstrated that SSRIs and SNRIs can reduce the frequency and severity of hot flashes by approximately 40 to 65%. A head-to-head trial comparing low-dose oral estradiol with the SNRI venlafaxine found that estradiol produced a 52.9% reduction in VMS frequency, while venlafaxine achieved a 47.6% reduction. Both were substantially better than the 28.6% reduction seen with placebo. Common side effects can include nausea, dizziness, and sexual dysfunction. An important clinical consideration is that potent CYP2D6 inhibitors like paroxetine can interfere with the metabolism of tamoxifen, a breast cancer therapy, making agents like venlafaxine or citalopram preferred choices for breast cancer survivors. While some concerns have been raised about the potential for long-term SSRI use to increase bone loss, short-term studies in non-depressed menopausal women have been reassuring, showing no significant alteration in markers of bone turnover. Modulating neuronal excitability, the role of gabapentin. Another well-established off-label option for VMS is gabapentin, an anticonvulsant medication. It is particularly favored for women who are troubled by night sweats that significantly disrupt sleep.
While its exact mechanism of action for VMS is not fully understood, it is believed to work by modulating neuronal activity within the hypothalamus. Clinical studies have shown that gabapentin is more effective than placebo and has an efficacy roughly equivalent to that of SSRIs, though it is generally less effective than MHT. Typical dosages for VMS range from 900 to 2,400 milligrams per day, often administered as a single dose at bedtime. This dosing strategy capitalizes on its most common side effect, drowsiness, to provide an additional benefit for sleep initiation and maintenance. Other common side effects include dizziness and swelling in the limbs, which tend to be most pronounced during the first few weeks of treatment and often diminish over time. It is important to note that gabapentin can cause withdrawal symptoms, such as anxiety and nausea, if it is stopped abruptly, so it should be tapered under medical supervision. A new frontier, fezolinetant and direct KNDY pathway antagonism. The most significant recent advance in non-hormonal therapy is the development of fezolinetant, brand name Veozah, a first-in-class medication that represents a direct therapeutic application of the neurobiological breakthroughs detailed in Part 1. Its development marks a paradigm shift from repurposing broadly acting drugs to precision targeting the specific molecular trigger of a hot flash. Fezolinetant is a selective neurokinin 3 receptor antagonist. Its mechanism is elegant and direct. It blocks the NK3 receptors in the hypothalamic thermoregulatory center, thereby preventing neurokinin B, released from hyperactive KNDY neurons, from binding and initiating the heat dissipation cascade. By interrupting this final, critical signaling step, fezolinetant effectively prevents the hot flash from occurring at its source. Pivotal Phase 3 clinical trials have demonstrated the robust efficacy of this approach. Treatment with fezolinetant at the approved dose of 45 mg once daily has been shown to significantly reduce both the frequency and severity of moderate to severe VMS by over 50% compared to baseline, with a rapid onset of action, often within the first week of treatment. The primary safety consideration identified in clinical trials is the potential for elevated liver transaminases, liver enzymes. This has led to a recommendation for baseline liver function testing before starting the drug, with follow-up blood work at 3, 6, and 9 months of therapy. Fezolinetant is contraindicated in women with cirrhosis, severe renal impairment, or those taking strong inhibitors of the CYP1A2 enzyme, which is responsible for metabolizing the drug. The thermoregulatory benefits of physical activity. Beyond pharmacotherapy, lifestyle modifications form the foundational tier of VMS management. Regular physical activity, in particular, has emerged as a powerful evidence-based strategy. The benefits of exercise are not merely related to general health but appear to directly impact the body's thermoregulatory control system. Research suggests that a consistent exercise regimen can lower a woman's basal core body temperature and enhance the efficiency of her heat dissipation mechanisms, such as sweating and cutaneous vasodilation. This effectively stabilizes the thermoregulatory system, making it more resilient and less prone to the exaggerated reactions that cause hot flashes. The clinical impact can be substantial. One study involving previously sedentary menopausal women found that embarking on a program of moderate intensity exercise, jogging or cycling 4 to 5 times per week, resulted in a remarkable 60% reduction in the frequency of their hot flashes. Standard public health guidelines, which recommend at least 150 minutes of moderate intensity aerobic activity, such as brisk walking, combined with 2 sessions of strength training per week, provide an excellent target for women seeking to manage VMS through exercise.
Nutritional approaches. From trigger avoidance to the Mediterranean diet, dietary strategies can also play a significant role in VMS management. A practical first step is for women to identify and avoid their personal VMS triggers. While these can vary, common culprits include spicy foods, hot beverages, caffeine, and alcohol.
Keeping a symptom journal can be an effective way to pinpoint these individual triggers. Beyond simple trigger avoidance, there is growing evidence that adopting a comprehensive healthy dietary pattern can be beneficial. The Mediterranean diet, characterized by a high intake of fruits, vegetables, whole grains, legumes, nuts, and healthy fats like olive oil, has been a particular focus of research. This diet is renowned for its anti-inflammatory properties, which may help to quell some of the systemic inflammation that can exacerbate menopausal symptoms.
While more research is needed to establish a direct causal link, the associations are compelling. A recent cross-sectional study revealed that women with the highest adherence to a modified Mediterranean diet had 80% lower odds of experiencing moderate to severe VMS compared to women with the lowest adherence. Given its well-established benefits for cardiovascular health, a key concern for postmenopausal women, recommending the Mediterranean diet is a sound, evidence-informed strategy. Phytoestrogens, particularly soy isoflavones, are among the most popular and widely studied dietary supplements for VMS. These plant-derived compounds possess a chemical structure that is similar to human estrogen, which allows them to bind to estrogen receptors and exert very weak estrogen-like effects. While this provides a plausible biological mechanism for their action, the clinical evidence regarding their efficacy is mixed and often overstated. A rigorous model-based meta-analysis that pooled data from 16 randomized controlled trials provided a clear, quantitative assessment of their true effect. The analysis concluded that soy isoflavones have a slight and slow effect on hot flashes. After carefully subtracting the substantial placebo effect often seen in VMS trials, the analysis determined that soy isoflavones reduce hot flash frequency by a modest 25.2%. This is only about half as effective as standard dose MHT. Perhaps more importantly, the analysis revealed a very slow onset of action. It takes an average of 13.4 weeks for soy isoflavones to achieve just half of their maximal therapeutic effect, compared to only 3.09 weeks for estradiol. This means women may need to take the supplement for at least 3 to 4 months before noticing a significant benefit, a critical piece of information for managing patient expectations. Mind-body interventions and complementary therapies, cognitive behavioral therapy, CBT and clinical hypnosis, powerful tools for symptom management. The experience of a hot flash is composed of two distinct elements: the physiological event itself and the individual's cognitive and emotional reaction to it. Mind-body therapies are powerful because they target the latter, which is often the source of the greatest distress. Cognitive behavioral therapy, CBT, has emerged as a highly effective, evidence-based, non-pharmacological approach for VMS. CBT does not aim to eliminate the physiological hot flash, but instead teaches women practical skills to change their perception of and response to the symptoms. Through techniques like psychoeducation, paced breathing, and cognitive restructuring, women learn to reframe negative or catastrophic thoughts, e.g., everyone is staring at me, I can't cope with this feeling, and manage the associated anxiety and stress. Multiple randomized controlled trials have demonstrated that CBT, whether delivered in a group setting or through a self-help manual, significantly reduces the bother and negative impact of VMS, leading to marked improvements in sleep, mood, and overall quality of life. Its efficacy is recognized in the clinical guidelines of major organizations like the UK's National Institute for Health and Care Excellence, NICE, and NAMS. Clinical hypnosis has also shown strong efficacy, with some evidence suggesting it may be even more effective than CBT at reducing the frequency and severity of hot flashes, with one review reporting reductions of over 6. Acupuncture and herbal supplements, a critical look at the evidence. While many women turn to complementary and alternative therapies, the scientific evidence for many popular options is weak or inconsistent. Acupuncture. The research on acupuncture for VMS is fraught with conflicting results. A key challenge in interpreting the data is the powerful placebo effect inherent in the treatment. Multiple high-quality systematic reviews, including a comprehensive Cochrane review, have concluded that there is no significant difference in VMS reduction between true acupuncture and sham acupuncture, which uses non-penetrating needles or needling at non-acupuncture points. Although some studies show that acupuncture is superior to no treatment, the inability to demonstrate a specific effect beyond that of a convincing placebo makes it difficult to recommend as a first-line evidence-based therapy. Black cohosh. Despite its widespread popularity, the herbal supplement black cohosh lacks robust scientific support for its use in treating VMS. A major systematic review that analyzed data from 16 randomized controlled trials involving over 2,000 women found insufficient evidence to conclude that black cohosh is effective. Specifically, there was no statistically significant difference between black cohosh and placebo in reducing the frequency of hot flashes. Conclusion: an integrated and personalized approach to managing menopausal vasomotor symptoms. The experience of menopausal vasomotor symptoms is not a sign of psychological weakness, but a manifestation of a profound neuroendocrine shift with a well-defined biological basis. The discovery of the central role of hypothalamic KND neurons and the NKB-TARIR signaling pathway has revolutionized our understanding, transforming VMS from a nebulous consequence of hormone loss into a treatable condition with a specific, targetable mechanism. This new knowledge underpins a clear hierarchy of therapeutic options. For appropriate candidates, menopausal hormone therapy remains the most effective intervention for VMS relief and osteoporosis prevention. The legacy of the WHI trials has provided invaluable lessons in risk stratification, establishing that for healthy women under 60 or within 10 years of menopause onset, the benefits of MHT generally outweigh the risks. The advent of targeted non-hormonal therapies, exemplified by the NK3R antagonist fezolinetant, marks a new era of precision medicine for women who are not candidates for or prefer to avoid hormones. Established non-hormonal options like SSRIs, SNRIs, and gabapentin offer modest but meaningful relief, while powerful mind-body interventions such as CBT and clinical hypnosis provide highly effective, evidence-based strategies to manage the significant distress associated with VMS. These interventions are supported by a foundational framework of lifestyle modifications, including regular exercise and a healthy dietary pattern, which can further improve thermoregulatory control and overall well-being. Ultimately, there is no single best treatment for every woman. The central unifying principle of modern menopause management is the imperative for a personalized and collaborative approach. The optimal strategy is derived from a process of shared decision-making, where a woman and her healthcare provider work together to weigh the severity of her symptoms against her unique health profile, her personal and familial risk factors, and her individual values and preferences. This allows for the creation of a tailored management plan that maximizes benefits while minimizing risks. The elucidation of the KNDY pathway has opened exciting new avenues for research, promising further refinements in targeted therapies and a deeper understanding of the complex interplay between hormones, neurotransmitters, and the brain. This ongoing scientific progress will continue to improve the health, comfort, and quality of life for the millions of women who navigate the menopausal transition each year.